Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi, I'm Dr. Princess Abadu, the Division Chief of Pediatric Allergy, Immunology, and Rheumatology at University Hospital's Rainbow Babies and Children's Hospital and Professor of Pediatrics at Case Western Reserve School of Medicine in Cleveland, Ohio. Welcome to this program entitled Timing Matters, Optimizing Biologic Escalation in Moderate to Severe Asthma. Joining me today is Dr. William Bussey, Professor of Medicine Emeritus at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. Welcome, Dr. Bussey.
Thank you. Good to be joining you.
All right, well, so we know that optimal management of asthma involves navigating a series of stepwise therapies depending on the severity of the disease. While the use of oral corticosteroids and inhaled corticosteroids remains a key component in the treatment and management of asthma and asthma exacerbations, the treatment paradigm is changing with scientific advances and the development of new therapies. Importantly, the most significant changes in the approach to asthma management over the last decade have been the integration of biologic therapies that target inflammatory processes underlying asthma and efforts to reduce and limit the use of oral corticosteroids. So, today we're going to be talking about these recent shifts in management of moderate to severe asthma, including how our approach to therapy is changing, what the latest evidence and treatment means for our practices, and where biologics are beginning to fit into the bigger picture. So, before we begin, we're going to hear from a patient about their experience living with moderate to severe asthma. As you watch this video, consider this. At what point did escalation shift from being just an option to a missed opportunity?
Hi, my name is Stacy Lewis, and I'm a patient suffering from asthma along with other chronic illnesses. On a daily basis, living with asthma for me is like walking a tightrope. Some days are really good, some days are really bad. So it's a fine line of, am I breathing? Is it okay? Is my oxygen level good? Am I struggling? And oftentimes I don't even pay attention to the fact that I'm not breathing correctly. So my sister, who's a nurse, I live with her. She'll say to me, "I think you need to do something. You're not breathing the way you shouldn't. You're not sounding properly." To me, it's more scary for me to try to go do something, knowing that I possibly am not going to be able to breathe properly, and then I don't want to say, "Hey, I really can't breathe real good today. Is it okay that I don't participate? Is it okay that I don't go?" And that could be if I'm trying to go to church on a Sunday and I get up and try to get ready and I'm expected to go to lunch afterwards with friends. And yes, I have a mobility device to help me, but it's the physical exertion of the exposure to outside air and the pressure of getting ready and preparing myself. So my use of steroids to treat asthma has played a role in the last year and a half to 2 years, being diagnosed with asthma and then other chronic illnesses. Um, it allows my breathing to be more sustainable for me. Otherwise, I would be hospitalized more often, that's the good thing about steroids. It helps me breathe, but the side effects have been horrendous on my body. My bones have become osteopenia in my left hip, down my left leg, and spread throughout my body in various places based on my bone density scan. In the past 4.5, 5 years, I've put on 85 pounds. Um, and that's more due to the increase of steroids and the inability to exercise like I was before. My body was used to moving and used to doing things at a higher level, and my lung condition has enabled me to where I just can't function at that level any longer. Um, so they keep me alive, but they're also slowly killing me. The use of steroids in proper dosage over a certain length of time is, like I said, keeping me alive, but it's also caused permanent damage to my heart and placing me in overall inability to work for the rest of my life because of the long term use and abuse of steroids.
Dr. Bussey, after hearing this patient's story, what really stood out to you about her journey?
I think a number of very important points. First of all, asthma is a complicated disease. Secondly, the burden of asthma on patients and families is many times huge and underestimated by everybody. Thirdly, patients with asthma can many times compensate for the severity of their disease. You can't see what the airways look like, and they will change their lifestyle rather than admitting many times that they're having a lot of trouble breathing. And lastly, we can rescue patients, but this is short lived and really doesn't affect the natural course or the progression of the disease.
I agree. I think we oftentimes underestimate the incredible effect on the quality of life of the patients and how far we've come with what we really can offer patients. And so, hopefully, as we talk through this today, we can really talk about a better way to look at controlling asthma for patients.
So, what are your thoughts about what the guidelines are telling us that we should consider when we're facing a patient with asthma, particularly severe disease?
Yeah, the change in the JANA guidelines, I think, is really a paradigm shift. And I think that it's in some cases been a little bit slow to be adopted. However, it's really appropriate that we start thinking about the strategies to help these patients a lot earlier, really, especially reduce the use of oral corticosteroids. I think using the LABA ICS as needed, and then, in the low dose and higher dose formats earlier on makes a lot of sense. We'll talk about this, but I really think about thinking about the comorbidities that the patient may have because it is a really heterogeneous disease. Patients have different other atopic comorbidities going on. The age of the patient makes a difference. So I think that having the GINA guidelines for the framework of introduction of biologics really is a game changer. But I think as clinicians, we really need to think about the individual patient and when to think about escalation, how early to do so. And there's so many factors that play a role in that.
One of the things to add to what you said that biologics have changed dramatically has been the need for systemic corticosteroid use. Again, we tend to use corticosteroids with exacerbations for rescue of symptoms when their current medications aren't working. But we now realize that although corticosteroids are effective in some circumstances, they can have profound and lifetime side effects. Again, the side effects can be quite profound as indicated by the patients. They can lead to compromises in bone structure. They can make patients more at risk for having pneumonias, and they really don't affect the long term effect of the disease process. In addition to that, we now realize that 4 bursts of prednisone in a lifetime is a risk factor for side effects. And these are data that we really didn't appreciate before. And the effects are not only on the metabolic changes, bone structure, and other things, but they really also affect the quality of life the patients are experiencing when they're taking corticosteroids, including depression and anxiety. The other change that has occurred is guidelines recommend using high doses of inhaled corticosteroids. And we are now beginning to appreciate that long term use of high doses of inhaled corticosteroids can also have side effects. And we've also begun to realize that the maximum benefit from inhaled corticosteroids is at considerably lower doses, about 250 micrograms per day of fluticasone. So we really want to look at how corticosteroids are working in asthma and also their side effects. And as I said at the beginning of this, one of the changes that has occurred with the incorporation of biologics has been reducing the need for systemic corticosteroids. The question, though, that needs to be addressed is we're waiting till the disease is severe. Should we be thinking about early introduction of biologics when the disease is less severe but is in a progressive phase? And if we do this, can we prevent some of the need for medications like corticosteroids with side effects, or can we affect the progression of the disease? And one of the studies that is ongoing is the AIMS 4 study, which is asking the question whether moderate severe asthma can also be benefited by earlier introduction. So I think that this is the step that we're looking forward to as far as getting new information on. So I'm going to turn it back to you to look at other aspects of where biologics have been beneficial.
I 100% agree with this. I think that it's a really staggering statistic that just 4 courses of oral corticosteroids can make such a profound negative impact on a patient's life. And we all know in clinical situations, patients that we see that will tell you that they've had multiple courses of oral corticosteroids over many years, and it's almost been a normalized thing. And so, really, it is so important to start considering escalating therapy earlier and to consider that impact of high dose or inhaled corticosteroids, particularly on the pediatric population. So we know that um, there really is a compound effect of having a lot of asthma exacerbations. So, the severe asthma research program studies have shown us that each exacerbation almost is increases the risk for future exacerbations. And we know that it's also aligned with lung function decline. So, we know that this is really an important thing that we want to stop exacerbations. We really want to think about prevention, and biologics are really an important tool here. We know that we can reduce the exacerbation rate with biologics. The studies show that between the approved biologics for pediatrics and adult, the reduction rate in exacerbations compared to placebo can be anywhere between 30 to 70%. So, pretty significant improvements in reduction of exacerbation rates. Now, there are studies looking at long term disease control, and that's a bit of a different question. And I think an ongoing issue that needs to be really fleshed out. The bigger thing here, and I would love to hear your thoughts on this, Dr. Bussey, is the concept of remission with biologics. And we know that there's a little bit of emerging evidence on airway remodeling too. But what do you think about this concept of remission?
Well, remission has been, as you indicated, a new way of looking at things. And if I could just amplify what you very appropriately said about exacerbations, exacerbations seem to be a very key factor in progression of the disease. Exacerbations lead to more exacerbations, and the cycle becomes very vicious and repetitive. It leads to compromises in lung function, greater susceptibility for exacerbation, and breaking this cycle becomes very, very important. One of the changes that has been entertained in asthma is to look at asthma like the rheumatologists look at rheumatoid arthritis. In other words, treating to remission. And by remission, I think we need to be very careful with what we're saying. What we're trying to do is put the disease into quiescence. In other words, silence some of the factors that lead to the disease to increase susceptibility for symptoms and exacerbations and progression of the disease. And if we can do this safely and effectively, patients are going to be able to restore their health. And then this becomes very important. You know, as a pediatrician, restoring the health in a child can be just absolutely, you know, life changing for these kids. They can participate in athletics, they can go to overnights, they can go to parties, and they can just be a normal lifestyle. Whereas in adults, it's allowing them not to always sort of be on the banana peel. Is my disease going to flare up so that I just can't do things normally? So the concept of remission, I think, is very important as far as therapy, but it also, I think, provides to the patient the feeling that there's hope. There's something else that can be done to make my disease less severe and therefore normalize my lifestyle. So that becomes important, and central to this is the possibility that we can change those processes that lead to this injury repair or remodeling changes that one sees, in asthma. So what are your thoughts, particularly in children, where I think this is so important? This is where the disease begins, stays for a lifetime, and you have this life cycle of disease, and it's really, very devastating, for people.
I can't agree more. I mean, um, the impact on the quality of life, the impact on the social ability to participate in school and work, all of these things make such a big difference. For children, we really think about prevention. That's the biggest thing. You want to have a child as healthy as possible. We've talked for decades about the atopic march. We know that children seem to start adding on atopic disorders fairly early in life. And if there is any opportunity to dampen that or to curb it, this is potentially life altering for a child. It could completely change the trajectory of their life. Now, we don't really have the studies yet to show that if you start earlier, you might be able to get complete remission, meaning remission off of the medication in the future. But these are amazing opportunities to impact this atopic march much earlier in a child's life to prevent use of oral corticosteroids, to prevent use of high dose inhaled corticosteroids, particularly in growing children. Um, so I really look forward to seeing how this evolves, how the research evolves, right? Because if we find that you could make these interventions earlier and they could make sustained differences or really change the medications that might be used, that might be required to control disease or even get close to curing earlier. We don't have that yet, but this is really exciting. It really gives us the opportunity to make an impact earlier.
If I could add to this a little bit, I think the other aspect of things is the guidelines have been so important to give us, markers by how we should treat the disease. But they also tell us to keep escalating the doses of medications to try to get to control. And as we become more sophisticated in understanding what's going on in asthma, we know that there are some people that are on the road to more severe disease. And just by escalating current therapy, which is not going to modify the disease, is not the way to get things under control. We want to know who these people are, intervene with our best product that we have available that can get down to basic fundamentals of the disease and then change the course of the disease. And I think that's why the concept of remission is so important. Biologics are providing us with tools by which we're able to accomplish this. And this is a new concept that I think we need to be thinking about in taking care of this disease.
Dr. Bessie, let's review what biologics we have currently approved.
Yeah, I think what we have is the portfolio is increasing at all times. Now we have a number of very effective biologics available. And I think this gives us a better opportunity to select a drug that is going to work best in individual patients. And figuring out the relationship, the best biologic for the right person at the right time, it's not as clear as we'd like it to be. We also know that randomized clinical trials have shown the efficacy and safety. But what's different with the randomized clinical trials is they have tremendous restrictions on who's enrolled. And it doesn't tell us about real world selectivity of patients, but we're learning more from some of these studies. And I think the other thing that we need to be doing is moving away from just symptomatic relief. And as we talked about with the concept of remission, getting back to what's going on in the airways, what is going on in the inflammatory process, and how can we really turn this off? Like an inflammatory bowel disease and rheumatoid arthritis, They're treating to basic causes of disease. And I think we need to be thinking about this at the present time in asthma, going back to the root cause and try to turn it off at the spigot rather than when it's expressing itself. So those are where we are at the present time, I think, as far as availability of biologic.
I completely agree. One thing I want to add to that is that we've seen this in other atopic conditions where we have seen lower and lower age approvals for these biologics. I think that there's an incredible need to have approvals lower than the age of 6. We know that many of these biologics have demonstrated safety and efficacy in children as little as 6 months old. And so, while if they have a atopic comorbidity, our below 6-year-old kids may be able to get some of these biologics. Those that are really struggling with asthma, there's a significant need, and we've already talked about interrupting this process much earlier to get better outcomes. And so I'm hopeful that we'll start seeing lower age approvals specifically for asthma with these biologics, since we know that it's already been demonstrated for many of these medications for other atopic conditions. So let's pause for a moment. I'd like you, the audience, to think about the following. What clinical signal should prompt escalation now rather than wait for another exacerbation?
I think one of the changes that has occurred is that we now have some biomarkers available. Asthma, when it's escalating, can be silent. We don't know when the disease is out of control until it expresses itself with a lot of symptoms. So I think the availability of biomarkers to tell us that the disease is active and its inflammatory process is ongoing has been very helpful. And again, one of the areas in which this has been helpful is the use of peripheral blood eosinophils and exhaled nitric oxide. These two biomarkers indicate that you have underlying inflammation in the patient, and this is reflected in their risks for further asthma.
Yeah, I completely agree. I will say though, in clinical practice, and I think you may see this same too, Dr. Bussey, that while blood eosinophils and serum IgE levels may be more readily obtainable, some practices may or may not be able to get exhaled nitric oxide levels easily, or may only be able to have spirometry in their offices. But having these are really important and really helpful. Sputum eosinophils are also a biomarker, and we rarely look at sputum eosinophils anymore. But if you have that data, that could be helpful too.
I think the analogy with cardiovascular diseases is something those of us in respiratory medicine need to be thinking about. I think everybody knows what their blood cholesterol level is, and they know when it's elevated, they're at risk for heart disease. With asthma, which is a common disease, we should know a bit about what your pattern of disease is. And being able to measure peripheral blood eosinophils is one thing, but also becoming more aggressive and involved with measuring exhaled nitric oxide gives us two profiles. And I think with the disease, which is so common, has such great degree of morbidity, we need to be thinking about how we can best inform ourselves and our patients and caregivers that these are individuals that we really need to look at, and we need to be far more aggressive in our forms of therapy. And it tells us about the nature of their underlying inflammation and whether or not a biologic is going to be effective for them. So I think it's something we need to revise as far as our readiness to use them.
Sort of just incorporate into our daily practice, or when you follow up with these patients, the same way that you would with potentially getting asthma control therapy information or other information, readily thinking about that information, having the patients informed or the families informed about what you're looking at could be really helpful because it allows for shared decision making. It allows for families and patients to be engaged in their care exactly the same way that we are engaged with other markers for other health conditions. So I agree with that.
I think some papers have come out recently and begin to giving us an idea about the profile. What is the patient who is going to be at greatest risk like? And we know their disease begins in adulthood. It tends to be more severe. We tend to see it more commonly in women. We find out if there's been some early compromises in their lung function. This is a risk factor, and the disease tends to be more severe. What we really don't know, though, is what is the pattern of evolution of the disease. Some people begin early on with mild disease and they progress to more severe disease. Others seem to just have the disease of greater severity, begin and continue at that level. But as we were talking about biomarkers, peripheral blood eosinophils greater than 300 cells per microliter, exhaled nitric oxide greater than 35 parts per billion. These are red flags that we should be aware of. If you're having to use rescue inhalers frequently, it's a marker that the disease is not under control. And even these short acting beta agonists can tend to accentuate the problems in the lower airway. And as you mentioned earlier, patients and their physicians give out corticosteroids more frequently than they should. And this should be definitely a warning, symptoms. So I think when we're seeing patients and when physicians and caregivers are seeing patients, they need to be thinking about all of these demographic situations along with biomarkers. And with this, get a better picture of the disease, particularly towards severity, and also to say if people are on the cusp of severe disease, we need to do things. Best treatment, maybe early on, can really modify their disease and also improve their lifestyle.
I agree completely with that. I think I just want to emphasize the point that you made also about asking about the oral corticosteroid use because um, we can't just look at the chart and look for ED visits or hospitalizations. Our patients now can go to the Minute Clinic. They can do virtual visits with different online platforms. They can get steroids very easily without you knowing exactly what's going on. And so I think that really asking about this makes a difference. But even considering having, we think about with our electronic medical records, we often have dot phrases or we have standard things that we check. Um, with your example for cardiovascular disease, et cetera, we might want to think about, as kind of um, providers, as practitioners, having standard things that you're checking every time, you're assessing every time, not only to know to start the patient on a biologic, such as the blood eosinophil count, the IgE, the exhaled nitric oxide, atopic comorbidities, which may very well help you decide exactly which biologic you want to start, how many oral corticosteroid courses they've had, but having this really routine and standardized so that you are checking it or you're assessing this every single time, I think that could be incredibly helpful, um, not only to thinking about initiating therapy, but how we manage them ongoing, because we all know that sometimes you have to make shifts in these therapies, um, depending on what's going on with the patient, and having something to follow makes a lot of sense there. So, Dr. Bussey, I would love to hear if you have any final thoughts or takeaways from these cases that we've heard about today and what we've been talking about with escalation to biologic therapy.
Well, I think both of us share enthusiasm for the changes that have occurred with asthma with biologics. I think, first of all, the disease when they're receiving biologics is very different than it was with our other medications. Secondly, when you talk to patients, one of the first things they talk about is I feel normal. And this is an important concept for them to experience and for us to realize that this really allows them to have a very normal lifestyle. It takes the undulation of the disease away. They're not one day symptomatic and another day not, doing well. it tends to smooth things out and they can have a more dependable lifestyle. And I think a very important aspect is taking away the risk for systemic corticosteroids. Although they are very powerful, very effective, they have side effects. And patients notice, and as far as their levels of anxiety and depression are concerned, and then years later, they have the consequences of it. And I think also, as you mentioned earlier, asthma is a heterogeneous disease. It's not one disease. And we just need to be far more aware of its many, many faces. And I think the other thing is the encouragement we've gotten from the safety of biologics, the possibility that if we can intervene earlier, are we going to make a better effect on the disease? I think that this is the next thing that we have to cross as far as really getting better disease under control. And it's an exciting time, both for us as physicians, but also as far as patients are concerned. It's hope. It's hope for them for a better life.
I completely agree. Just the impact and the ability to take away the need for multiple courses of oral corticosteroids is life changing. And I think we don't always appreciate the impact on the quality of life and our ability as providers that take care of these patients to really be able to intervene and make a difference that could really change the trajectory of someone's health. Um, I am so excited to see how it will continue to move in the pediatric world because I think that early intervention we know makes such a big difference with a lot of atopic conditions. I think that I'm really hopeful with all of the information that we have now for biologics that PCPs understand to refer to specialists early so that we can start working with patients early. I can't begin to emphasize how important shared decision making is for both patients and families. And so, for them to have some understanding, for them to understand the numbers, as we have talked about before, to know that there's hope that you can escalate to biologic and they can potentially lead quite normal lives is really important. And so, this is a really incredibly exciting time for the field because I think that there's really an ability to make a difference and to really help people here. So, Dr. Rusty, this was fun. I want to thank you for a great discussion. I hope this was helpful for everyone. I want to thank the audience for participating in this activity. And I want to encourage everyone to continue on to answer the questions that follow and to complete the evaluation.